Now we'd like to kick off with John Wilbanks. He is, again, Chief Commons Officer at Sage BioNetworks. Previously, John worked as a legislative aide to Congressman Fortney Pete Stark, served as the first assistant director at Harvard's Berkman Center for Internet Society, founded and led to acquisition of the bioinformatics company Inselico, and was executive director for the Scientific Commons at the Creative Commons. Following John's presentation, we'll proceed straight into Meg Dorr's talk on informed consent. A former teacher and botanist, Meg joined the genetic counseling community in 2006. She led the clinical development and implementation of Cleveland Clinic's family history and risk assessment tool before joining Sage BioNetworks in 2015. As principal scientist at Sage BioNetworks, Meg's efforts have been concentrated on supporting innovative, participant-centric approaches in open science, including the All of Us research program. So without further ado, I welcome this awesome team from Sage BioNetworks, and let's welcome John to the stage.
Good morning. Thank you, Christian, and thank you, Nicole and Global Genes and everyone for having us here today and for flexibility that you didn't see that was required to make this possible. I'll point out that we are currently not at the IRB meeting for the All of Us research program, which is in the other side of the country, so that we can be here today, because this is something that we deeply believe in. How many people are here from a different time zone? Oh, I'm sorry. So welcome to DC in late July. On the plus side, it'll rain. On the downside, it won't make it better. So I wanted to start with just some disclosures. I'm an advisor to a variety of startups in this space, mainly from an equity perspective. I'm not a lawyer and I'm not an ethicist. I have spent most of the last 20 years translating for those communities to other communities. So if I make mistakes, those are on me and not on the people that I work with. And everything I'm going to describe is free of charge and free to use without asking any permissions of us first. So we're a nonprofit organization at Sage, and everything we do is free for you to take and use without having to contact us. I was trying to think about, because I expected a lot of you to be coming from a different time zone, how to keep you awake in the morning. And also dealing with the fact that Megan and I usually don't speak in the same place at the same time, and so one of us had to write a new talk. And that person's me. And I was trying to think about, sorry, go ahead. It is Megan's birthday, by the way. Again, she's missing the IRB meeting for her biggest piece of work at scale that can be imagined, as you'll see, and it's her birthday, and she has come from Seattle to DC in late July to be with you. All of the cool stuff I say, Megan is probably responsible for. So I was trying to think about, right, how am I going to talk to this crowd? And I spend a lot of time talking to researchers. Most of what we do at Sage is not patient-centric or participant-centric, because our job and our charge is to try to gather the research communities together to make them more effective and hopefully make the claims that come out of research more verifiable, more stable. Because, I don't know about you, but I don't know if coffee is good or bad for me this week. Right? The stability of a claim in science is not very stable, because we don't know what next study will come out that will overturn the fact that we thought was a fact last week. And most of what we do at Sage is meant to address this specific fact. And that's where we started, is how can we gather researchers and build researcher-centered communities where they actually use technology intelligently, where they share the way software developers share in open source communities. That was our charge at our founding. But along the way, we discovered that in order to complete that mission, we had to change the way that research data were collected, because it's very hard to build research communities that use technology and networks and that have researchers sharing with each other without intervening farther upstream in data collection. And that meant engaging with patients and study participants. And Megan will go into the details of how we do that. So I'm going to give you more of, I've been at the org now for a decade, and I do think we have this remarkable opportunity. and I'm going to try to explain why I think it's an opportunity. And then, as hopefully keeping you entertained, I tried to have movement in my slides. Now, you're going to see me using some of the things that Megan's going to talk about, which is if I want to draw your attention when you are in a lowered mental state because it is a different time zone and it's hot and you're tired, I have to do something with the interface to draw your eye to it. Right? And so these are some of the statements and things I've noticed about working with rare disease communities, because we wind up working with rare disease communities on a regular basis because they come to us and they say, how can we get some of that researcher community that you've got? And what I find with these groups, people say, I don't really know how, but I've got a data registry, and I think I need to govern it so I can get it to a researcher community. Right? This is still my favorite one, and this is Megan here, Lencho Boyle? Is Megan? No, Megan? Okay, well, Megan will be here a little later. Like, this is my meeting with Megan, is like, I have this PCORI grant, and I've got to get the data to Harvard, and I'm trying to deal with the board of my foundation and figure out what our governance needs to be to maximize the benefit of the data. You know, I had to find one of David Byrne's sweating for this one. And I think this is why we're here. You know, everyone here has a data governing need and wants to turn their registry or data product into something that is more, whether it's more people looking at it, more people contributing to it, networking it with other similar kinds of registries. But we're all in this world that we didn't invent. I don't think anyone in this room got up, you know, a year ago and said, God, I really want to get into data governance. Right? But you're here. And so I think it's good to maybe then go back and say, where did this all come from? And that's the last gift for a while, I promise. So registries are over 150 years old. Right? The first registry, right, this is the one, the best thing that I could find, came out of leprosy research 150 years ago in Scandinavia, as far as I could find. And the origins of it are fascinating, and they teach us a lot about, I think, today. Right? It is a result of political mobilization to provide health care to those in needs, as well as epidemiological surveillance, and processing of its data would give the clue to the cause of leprosy. Right? I don't think that this has changed. I think this is why we do all of these things. I think that there is political mobilization around rare diseases, certainly around non-rare diseases. I think the number one reason we do this is to make healthcare better. I would argue that that's in many ways what this is about. Epidemiological surveillance is one of those side benefits you get from a society as part of giving healthcare in a data-driven way. And I'm afraid that the cause of the disease has taken over the vast majority of what we do. And that's something I want to talk about for the rest of the day is how can we achieve these goals at the same time without the research system capturing the vast majority of what we do on behalf of the final charge here? Because we have an entire sort of research industrial complex that wants to take any data or any money and turn it into biological causal investigation. And again, this is what we do at Sage. I'm not like against that. But I think if you're coming from the position of a rare disease group, that it's important to not forget the healthcare part and the epidemiological part. Right, so this is not new, right? This is not actually once in a lifetime and how did we get here? This is where we've been for 150 years. And depressingly, going to technical systems has not radically changed all of these things. This is the filing system that we started with, right? This is the modern version of that filing system. Right? And this is what the surveys look like when you put them onto a phone. Interestingly, things like copyright law make it illegal to rip this apart and make it useful on a phone. So you can't show the pictures on a lock, you can't show the questions on a lock screen, or let people answer question 1 and then question 2 later, because that represents a derivative work of the creative work of the scientist who structured the questionnaire. And it makes it very hard to digitize these things, just as the way that we've done our electronic health records makes it hard to use them in this context as well. But this idea that we basically are sending surveys to people and people are filling out those surveys is still the root of the vast majority of what I've seen when I encounter people's data, right, out in the wild. It's a lot of survey data, a lot of demographic data, and then there's kind of a hodgepodge of stuff that has been jammed together, usually coming out of the electronic health records. Right? And so supposedly this changes everything. I'm just keeping you awake, right? That's what the GIFs are for, right? I have to draw your eyes to this stuff because you will get bored. The more text I use, the less you listen. This is going to be important in the next talk. So I did a search for cliche pictures of big data in healthcare on Google Images. This is not an insult to the Catalyst project, which I love. But if you have ever spoken to a consultant, you've seen a picture like this, generally close to a price tag. And the idea is that all of this is going to fix everything, right? And that everything is new, and this is a once-in-a-lifetime opportunity, which is a buying pressure tactic, right? The whole concept of once in a lifetime is a pressure tactic to get you to buy things, right? When I did my startup, my sales guy taught me the trick, which is there's only 2 left. Right? We're sold software, right? But it works, because you say, we can't handle the second. We've only got 2 client spaces open. And so this is what's supposed to fix and change all of these things. So Invitae, which is one of the big corporate players in the space, and again, not attacking them, they're completely good players, right? They have taken this concept of the registry and moved it to the Patient Insight Network, and it's interesting to see what they market going into that. So you can take surveys, right? That's always the first thing in all of these cases is surveys. Upload your medical records, right? Track your health outcomes, which is another form of saying you'll take surveys about your health outcomes, and then you'll learn about the latest research and trials. So this is a large, well-funded Silicon Valley company. It bought Patient Crossroads, which is one of the biggest registry software providers, and it's still fundamentally, you can take some surveys and you can upload your medical records to us. That's the state of the art here. And then you think, well, phones are going to change everything. I've heard about these research kit apps, and I've heard about all of these technology stacks that are going to make it easier for at least the health records to be useful. And then again, you ask, so we'll start doing this, and things will get better right away. And I don't know how many of you have taken the step into the health record space, but this is the kind of picture you're presented with as soon as you get in. This is, that's the appropriate response. So, if you know what all these acronyms mean, you're better than me. We work with OMOP, and I don't really know what the 4 letters stand for. I do know the CDM stands for Common Data Model. There are competing common data models, which means they're not actually common data models. Right? It is nearly sectarian conflict between the informaticists as to which one you should use, where, and why. And most of y'all are dealing with family members who are ill. And you're supposed to stop and learn this? It gets worse, right? This is, if you've heard of Smart on Fire, right? Again, it sounds great. Actually, these are great technology stacks, but they're nearly impossible to use for non-informaticists. And I encourage you to download any of the various bingo cards that are available for the buzzwords in this space. And again, lots of these are long acronyms. Who here knows what macro means? Right? I embarrass myself when I go to the informatics communities because I don't know what these words mean. And so part of what I'm trying to do is to give you permission to acknowledge how insane this all is, right? When what you're trying to do is to build something that actually makes healthcare better for your community and leads to better research for what you're doing. It's really hard to do that. And it's because the research system wasn't built for you structurally. It wasn't built for healthcare, and it certainly wasn't built for people engaging in it who were not researchers. And so, again, I want to start with some history. How did we get here? So this is a guy named Vannevar Bush. Anybody here ever heard of Vannevar? Arguably one of the most important, impactful people in United States science policy in the last 100 years who none of you have ever heard of. So he worked for President Truman just after World War II. Arguably created the modern United States research academic policy system. Also arguably was the first person to conceive of the internet as we now use it, all within about a 2-year period. This is a great book I would recommend by Audra Wolfe that lays out the reasons why we have the scientific system we have. It was in many ways an anti-Soviet approach. So the Soviets had lots of geneticists who said things like, if you stretch your neck, your child will have a long neck, right? Lysenkoism really dominated. And so we had to have this opposite approach, which was rational, scientific, neutral. But it wasn't neutral or rational, it was political from the very beginning. Science has always been political, and this is why when people tell you not to mobilize politically, I would tell them to pound sand, because science is political and you need to engage in it if it's going to work. But it's a great book, and it really starts to outline why do we have these weird systems where we give taxpayer dollars to the government gives those taxpayer dollars to a department, the department gives out grants, the grants go through peer review, and the results are published in journals, and then of course you have to buy them back from the journal providers. This is his article about the internet, this envisioning of the Memex. And there's this great quote in it, which was true in 1946 and remains equally true today. Right? The fact that this system that he designed, which is, it worked very well for a long period of time, its primary output was journal articles. And that is still, arguably, its primary output, along with patents that no one ever licenses. Something like 95% of United States university patents are never licensed to a single party. Yet we still encourage them. The vast majority of papers receive no citations, yet we still optimize for those papers. Right? This is what the system is built for. It's built for scientists to take money and publish papers and file patents. It's not built for you. And it's not built for your data. Because in a lot of ways, the scientists are trained to only analyze the data that they create and to only analyze it for the purpose of publishing their paper. This creates what we're trying to get this phrase popular at SAGE, this concept of massive incrementalism, which is really what we do. We fund the smallest possible pieces of research at the most massive possible scale under the hopes that we'll be able to assemble it later and understand biology. And it's really, really hard structurally to do this. What's our output? This is my friend Heather. She's published, and this is several years old at this point, but I don't think the numbers have radically changed, that per 100 grand we get between a half a paper and 5 papers. It's usually closer to half a paper for the most part. And that's research productivity. If you are a scientist going for tenure at Harvard, or even, I'm from East Tennessee, at the University of Tennessee, Knoxville, you are judged on the number of papers and the places that they are published and nothing else. Show me your Cell, Nature, and Science papers or go home. People in the space call it CNS disease, Cell, Nature, Science, right? And it afflicts the vast majority of the scientists that you want to look at your data. How effective is the system? We're looking at 800,000 plus papers a year now. So, think 365 days in the year, 24 hours per day. It would take you a lot of reading per hour to read every paper. And cognitively, you wouldn't be able to process all of it. And so you have these nice initiatives that do things like, let's integrate all of this into a metabolic pathway drawing that shows causal biological relationships, because this is, in theory, what we actually want. This is the pathway for Alzheimer's disease. It looks very rational, right? Yeah, we can't drug it. And in fact, the dominant scientific theory, which all of the research panels, all of the review panels, all of the journals maintained for 20 years, was that amyloid beta plaque buildup in the brain was the cause, and if we could reduce amyloid beta, we would stop Alzheimer's. Something like $18 billion later, the scientific is like, well, oops, right, wrong theory. Right, this is why SAGE exists, because there was no way to judge whether the claims underlying amyloid beta were actually valid or whether they were the results of incrementalism where things were sort of right in the individual and then they stitched up to become truly wrong in the aggregate. But it traps you. It traps anyone who tries to get into the research system. And part of this is just because biology is complicated, crusty, weird, old, and unpredictable. And so there's a variety of saviors, right? So AI was going to be the most recent savior. And I say this, I am complicit in this system. I am funded by this system. I have worked in the system for 20 years. I have been a believer in the saviors at different points. I no longer really believe in saviors in this space. I think there's a lot of great work to be done. But I'm very sort of nervous when anyone says, like, technology X is going to fix it, or process Y is going to fix it. right? The end game of the last 20 years, I've been in this for 20 years, this summer actually, was when I got into biotech and bioinformatics. The end result of 20 years of innovation in technical systems, from microarrays all the way up to CRISPR, in process innovations, right? Every big pharma, every 5 years, tries to reform itself in a way that's truly remarkable. They'll restructure themselves around therapeutic area, around position in the development process. They do more investment in internal sort of innovation than any other industry. Like, it's nothing like cars. They're trying. Everything we do makes it more expensive. Everything we learn makes it harder to find a drug. And that's why you see this, this formulation of it's Moore's law, but in reverse. And that's the end game of the last 20 years of all of this money, all this knowledge, all these papers, all this innovation. And so, for the last decade, open science has been the latest magic bullet that we're going to fire at the system and fix it. If we share all the papers, if we share all the data, it's going to all stitch together, and drugs are going to fall out, more or less, I would describe as the thesis. It hasn't worked, right, obviously, but let me show you the things that do work in open science, because these are some of the things that you might design for over the next couple of years. So colorectal cancer is a good example. Here are 4 papers from 4 labs, each of which saying that they have discovered the true molecular subtype for colorectal cancer. If you read the papers, you would not be surprised to discover that none of them have the same molecular subtype for colorectal cancer. They each have different data sets, different subpopulations, different algorithms. And they compete with each other, so there's no reason to collaborate and share any of this. So what an organization like Sage can do, or what open science can do, or what integrating your data on the back end might do for you, is to enable us to see what's the truth across all 4. Because a fact that emerges from all 4 of these labs organically is way more likely to be true than a fact that only emerges from one. Because that one might be statistically significant, it might be publishable, right? But it might be an artifact. Because the way that we analyze data looks for patterns. And those patterns may be significant but untrue, or meaningless, or in worst cases, confounding. They may point the arrow the wrong direction. So what we were able to do, and this is something that our founder did, he basically flew around to all of these labs over and over and over again for 6 months and convinced them by saying, well, I know you don't want to share with each other, but if you all shared with Sage, then each of you could go from this sort of linear process to this world where each of you gets 6x data in return for your 1x data contribution. And we kind of stopped at this point in the sales pitch to these folks, right? And we said, every new member that joined is more data that helps you analyze, and you're going to write a new paper about how your algorithm got better when we added more data to it. But the catch was, right, because we're a nonprofit, we don't sell this for money, we sell it for value. Social value was, we're going to collectively analyze all of the data and publish a paper on top of it that says what the actual consensus subtype is. So each of the 6 labs gets to write a paper about their own, but then we write a paper that says, here's the ground truth across all of it. And by the end, you have labs petitioning to join because they don't want to be left out. Because scientists hate to collaborate, but even more than that, they hate to be left behind. The number 1 way to motivate a scientist, is to move their funding. The number 2 way is to make it apparent that a different scientist will outcompete them for funding in the future. And that's the system that we're trying to get set up. And so you have this very powerful system where we say, here's the actual subtype. Because this is the stuff that's stable when you add data. It gets stronger when you have more patients in the sample, not weaker. So that's one of the good things you can do with open science. Another thing you can do is try to propagate truth up the line. So Alzheimer's, we do a lot of work on Alzheimer's. We've done a lot of work trying to do precisely what I just showed you, but in Alzheimer's disease to find new drug targets. Because clearly drugging amyloid beta doesn't lead to better Alzheimer's outcomes. We're 5 years into that, that's worked pretty well, and now the NIH is saying, let's do the same thing for drug discovery. Because the idea is if we can actually fund new compounds that hit the new targets, and we make the new compounds themselves public domain, then all the competition is on small innovations on the side of it, and so the market can go straight to looking like statins, instead of going through the phase of $1.7 million per person per year. Right? And so what you have is the NIH literally baking in the consensus targets into their funding announcements. And so this is how we have had to try to create value at Sage, because we're not a magic bullet. We're more like an infectious disease that moves upstream. And you can have a ton of impact, but it's a decades-long process. And so when we work with patient groups, right, they see this and they understand intellectually that it's progress, but it doesn't help them. And that's part of the difficulty is our research system is set up for a different time scale than the experience of healthcare and the experience of chronic or acute disease or conditions. Another fun thing you can do is try to eliminate bullshit, right? That's a technical phrase, I apologize. I'm not very formal, I'm sorry. There's a lot of bullshit in data analysis, right? My company did not have a ton of success, right? We sold it on paper, but none of us made any money. And one of the criticisms we got from one of our investors is that we were too focused on the truth. Not from anyone who invested in us, right? This is one of the reasons why someone passed. And so the joke was, if we had just made a data analysis window that said, what's the result you want as a researcher, and then we had configured the back analysis to provide that to them, I would probably be rich and not standing here. And this has gotten worse because it's gotten easier to do the analysis. You need less expertise. You can craft algorithms very trivially. The algorithms, again, they appear to be significant, but they're trained on small data. They're trained on non-diverse data. They're trained on data that reflects structural systems of oppression in this country on a regular basis. And so you have Amazon saying, oh, our algorithms are race neutral. They just happen to not deliver to black neighborhoods. Think about that in the sciences. We already have this. There's a reason why women of color are way more likely to die in childbirth than white women. And we're going to entrench that if we build all of our algorithms on the systems that basically built in those kinds of structural barriers. And if we're not going to benchmark algorithms, right, they're going to keep doing this in health. Publications are not ready for this. Publications want you to write a paper that describes your algorithm, and then we'll review the paper that describes it. It would be way better to say, have you passed a public benchmark of bullshitness or not? And this is something Open Science is great at. You could say, we're going to have a competition to analyze digital biomarker data from Parkinson's. This is a challenge we ran. And now, if you're doing accelerometry data coming off of mobile devices and you can't beat the benchmark on walking analysis, you shouldn't get published. You sure as hell shouldn't go to the FDA. Right? Open Science does these things. They're valuable. They're really valuable. They are not going to find a cure for you in 24 months. Right? Because it doesn't fix biological complexity, which is one of our enemies here, and it doesn't fix the fact that the research system wasn't built for you. Okay, a few more gifts, and then I'm going to hand over to Megan, and Megan will tell you how this all works and some more details in consent and governance. Because I'm just here to provoke you. Right? Anytime you're the first keynote, your job is to provoke. Right? So this is me when I got into this. Right? And this is scientists to me. Right? They don't come. If you open up your data, scientists won't come. Not the way you think they will. We spent 18 man-months curating a data set that Merck donated to us in 2010. Including the woman who's now the president of the organization and the guy who's in charge of all of our external partnerships. They were the two people who spent 9 months together curating, annotating the data set. How many users do you think we would have? How many people here think that there are less than 2 users of that data? Because that's the correct answer. There's less than 2 users over a decade to that data. And it's not because it's bad data, it's because we misestimated the market research. There's a clinical trial data sharing site, got 2,500 plus clinical trials donated from the pharma industry. In its first 9 months, it had like 3 requests. They had to run a challenge where they gave cash prizes to successful applicants of $1,000 each to stimulate access requests to the database. Right? Open Science doesn't work the way that we thought it would work. Scientists aren't sitting around going, man, is there somebody else's data that I can go learn how to use and use? They're focused on their lab goals, their incentives, their papers, and getting the next grant so they don't get out of business. And my argument, the reason I raise all of this, the whole point of my talk is that I think that you're the latest magic bullet. Because the system depends on the existence of magic bullets to avoid structural change. right? It's very easy to say, we don't have to change the way we give grants, or review grants, or publish papers, or publish knowledge, or review knowledge, or the way that we work. Because as long as there's a magic bullet that we can write on top of our grants in the first paragraph without changing anything else in the grant, we don't have to change. That's what I think is going to happen to this community if we're not careful and if we don't really get our hands dirty. And that's why Megan and I are here. That's why we're here tomorrow. Right? This is why we think this is so important. There is actually an opportunity, if we get this right, to avoid the magic bullet trap. But part of it comes from building our own system that can be accessed by the research system instead of being co-opted by the research system itself. Right? Because like open science, right, I think patient centricity is very useful. I also think it won't fix neither of the problems that open science failed to fix. Right? I'm not saying anything about the scientist. I was really hoping I could make Megan laugh, so I'm happy. Scientists want to science. You know, I cut my teeth as an advocate in the open access wars, right? Access to the research literature. The first thing a scientist had said to me after my first big talk in it was, if I make my paper open access, the patients in the study might call the lab. It's like, yeah, right? But you know, this is really difficult. This is really difficult stuff because the culture of science and the expectations of science have zero connection to the culture and expectations of patients. You know, all the way down to, well, I'm studying your disease that your child has, and I've published a paper on it, and some external database has characterized your disease with my name because I'm the last author on the paper. Not your own family's name, and you have no agency over that. And the author of the paper has no agency because the system is set up for this. And everyone involved can say, you know, I'm just a scientist, I'm not involved in this. Right? This is also from Field of Dreams. I think this is my last GIF. So I don't want to just beat up on scientists, right? It's really hard to be a biologist without focus. Right? There's so much in complexity that there's a lot of value to the scientist in keeping his or her head down and staying focused and not getting distracted. But all of these things add up, right? They intersect in a way that makes it very hard for you to work with them the way that you want to work with them, where you're in charge of some research questions. And their first answer is going to be, do you know how to design a hypothesis? And it's not invalid for them to say that, right? It's worthwhile learning some of their language so that you can talk to them, but it's also worthwhile being empathetic to them as people, because at the same time that they're not always empathetic to you as people, one of the best ways to get someone else to be empathetic with you is to be empathetic with them and recognize that they have a weird, hard life too. If they wanted a normal life, they would not be a scientist. They would especially not be an academic scientist. And it's getting harder and harder to be a scientist. This is a complicated graph. What it shows is that the age at which you get your first major NIH grant, which is the R01 Classic Investigator Grant, is increasing and increasing and increasing, which means that young people, right, so a person who's getting their first R01 right now is just a little bit younger than me. I'm about to be 47 in a couple of weeks. So think about that. I graduated from college in 1994. If I got my PhD, which I didn't, I would have gotten it in 1999. I would be in the middle of my first grant. Think of how long it took for me to get there, right? How much competition there was, how unlikely I am to change the behaviors that led to me actually being one of the rare few who gets this grant. And this is despite a solid 15 years of intentional, funded policy work at NIH to reverse this trend, right? The structures are not our friends. I forgot I had one more. And so one of the scientists that I worked with, we were trying to do a patient-centered project, and we did some interviews, and she said, well, you know, I'm in the East Coast. I ski on East Coast mountains, and they suck. They're small, they're icy, they're crowded, but they're my mountain. And I know if I ski it every day, 5 days a week, for 5 years, I'm going to get my grant renewed. And what you're asking me to do is to voluntarily blow both of my knees, have surgery, in order to ski on your big hill someplace else. And I don't know if I'll be able to ski it. And on top of that, if I am able to ski it, I don't know if I do that I'm going to get a paper at the end of it, and I'm going to get my grant renewed. And we're stuck in this, right? This is why the Field of Dreams marketing plan failed for open science, is that all the scientists look, they go, that may be a nice hill, but I have no idea if I'm gonna have a job in 5 years if I go to it. So don't fall into these traps, right? And this has been a downer of a talk, despite the gifts, right? But the good news is, it's actually liberating, right? You don't have to focus on this stuff. The existence of the system helps the system focus on biological causes. And if you can learn ways to feed data to the system in a way that it is ready for, they will use your data. Right, so expecting them to come to your website, register for your registry, and then download the data, that's probably not going to work. Making the data available through a modern platform, using things like APIs, which is a fancy way of saying an interface that lets a programmer call your database without going to it. Right? Scientists love that stuff. Because what you're doing is you're adding to their data, and they can see if their hypothesis gets stronger or weaker. They don't want to publish crappy stuff. They just get rewarded for it. If you can give them easy tools, they'll use it. They'll use your data. And they'll go to the data that's the easiest to use. And so the kind of work that Nicole and Global Genes are doing with RareX, right, around this is essential to this kind of movement, because it recognizes that strong technical underpinnings on the back end of this and commonality can feed these kinds of dual uses. The problem is that we've been engineering for the research users as the first and all of the patients as the second, and not creating them as dual use. But if we flip that and we say, what if we designed it for patient use, and then there was a dual use to the research system, there's a real path forward here. There's a lot that can be done. But this is why governance is so important. If you don't set up the consents right, the governing documents and the protocols right, the dual use is blocked by default. So we did things like this on some of our mobile apps. This is where the data came from for that Parkinson's challenge, right? We can do dyskinesia, tapping on the screen. It gives you things like tremor measurement, as well as just basic dexterity. We can do gait and balance by using the accelerometers in the phone. The microphone gives us muscle tone, right, from the voice box, as well as a little bit of knowledge about lung capacity. And we can even do memory tests. And these are just 4 small things on a phone that we can measure. Now, the difference is what you see from a scientist, right? Because the scientist goes, wow, this is high dimensional data. Look at how many things we're getting on the phone compared to a traditional measure, right? We can do things like discover that in many cases, some people don't get their benefit from L-DOPA and the number of taps, but from the accuracy of tapping, and that would have been invisible under the old measure. It's nice. Right? You can see, right, this is a specific thing. We have one person who benefited in terms of number of taps, and one person, their tremor went down. They would have been invisible under the old system. Right? You can actually start to get at the lived experience of a disease. So this is, when you see these red arrows that are pointing up, those are good days where the tapping got better after the meds. The down arrows are bad days. Those are days where the tapping got worse after the meds. And this is a hypothesis for this one person. Because something happened, right? Something happened right here in the middle where you went from lots of good days to a bunch of mixed days and then back to good days. There's a clinical hypothesis in this for that person. The scientist doesn't care about that. The scientist sees all these data and says, what can I learn about the fundamental biology and progression of the disease? And so if you design for Beaker, you get Beaker's questions. So this is the question that you should design for. And then you feed the data to Beaker through technology. This is how I think it's going to work. Right? Because it doesn't expect the structural issues and barriers in our research system to magically change. Right? And it doesn't expect them to answer your questions. It expects us to answer our questions. And then we feed the data to the scientists in hopes that the scientific system actually does the science it needs to do over the time. Right? So we have to be more like scientists ourselves. He's an evil character in the Marvel Universe, so I apologize, but it's the best one I could find. Right? And so dual use. This is one of my favorite examples of dual use. This is a Braille alphabet overlaid on top of an English alphabet. Good design makes it readable to both groups at the same time instead of having 2 separate ones. That's what I think is the answer here. And that's why we're such big fans of what's happening in this space with what CZI is doing. But it also really does illustrate this fundamental weakness, which is most groups don't have any governance experience or expertise. Governance is hard. I loved Christian's comment that it's like management. It's almost meaningless because of how many different meanings it has. But at the end of the day, governance is writing down what you're going to do, how you're going to do it in advance, and getting it reviewed by independent external groups. Right? It involves bringing together stakeholders. It is boring, hard, and awesome when it's done right. And so, right, it's really useful patient centricity, but it needs to start with what questions are relevant to you, and what can you do to gather that data and get it analyzed, and then, and only then, how do you feed that data to the research system? And if you set this up right, technically and legally, you can do both. Because right now, for the most part, as far as I can see, most of the patient-centered data has been captured by the research system. You may still have a copy of it, but most of the useful value improvement to that work happened in a research institution and not at your place. And so the question really is, how can we fix that? Right? Because you want the scientist to be an added benefit, right? Not the focus. And the hard part about what we've got is that the scientist is at the center of this. Right? The scientist and the scientist institution are at the center of this. And so flipping this on its head and saying the questions that you care about matter most, and then making sure to feed it to the system as part of the ecosystem is the added benefit. And so, that's why we think this is important. Because most of the vendors today want to be in the center of the system. They want to be Amazon, they want to be Apple, they want to be Google, they want a network effect. And I'm not sure that a vendor, a for-profit vendor centralized cloud system is what solves this problem for the best, right? Because the reality is, like Facebook, if you're in Facebook, it doesn't feel like a walled garden. It feels like the old internet felt like, but there are walls, and they own it. And the kind of things that are happening around, again, the RareX initiative here, have the potential to take us to a different way of thinking about this. And so to the extent that you can own your node, right, instead of renting your node from the central vendor, this can work. That lets you have local governance that's appropriate to your community. It lets you make changes. You can hide your node from the network over time. You can expose it when it's the right thing. It gives you the autonomy and the agency over your technology and your governance in a way that a centralized system doesn't, right? A centralized system is very much the Model T sales pitch, which you can have any color you want as long as it's black, right? You can have any cloud you want as long as it's Amazon or Google. So to the extent that these systems are controlled and run through entities with different classes of business models than platform capitalism, there's a chance here. There really is a chance here. Because we haven't really made that transition out of the old registries to the new world of registries yet. And we're in the middle of that transition. It's not going to be like this forever, and it's going to either go the centralized way or a different way. And that's why we think this event is important. That's why we think that y'all are important, is that if we can convince you to do this, we think we have a chance at building a much healthier research ecosystem than the one that we're being forced into these days. Because this is the worst. Right? The worst is incremental advances on broken systems. And I will leave you with my last cheesy metaphor. So you're not going to remember this sentence, but you're going to remember this. Right? What's an incremental advance on an ear? Right? And what happens when you play this out, right? This is our research system. Right? Ears were a good idea. And for a long time, the ear horns made a lot of sense, right? We have to be radar. Thank you. There's more attribution. Sorry, that's the rest of Sage, and I'm required to do that. Yeah, there we go.